Let's take a peek. A couple more slides, we'll move on to heart. I'm going to bring my viewers at home, if there are any, in closer. If there aren't any now, I'm sure there will be in the future. Okay. Yeah, could you turn it off, please? This is a tough one. Where are we here? Talking about aneurysms. So where are we here? You have to sort of follow the vessels proximal and distal, right? We're talking about aneurysms.
Is it abdominal?
Mm-hmm. Biggie, right? And it's kind of almost displaced. You could see the aorta proximal. You could also see what? Lateral to it. The kidneys, right? And then you could see very faintly distal or inferior to it. You can see that bifurcation of the common iliacs, okay? That's a big one. How'd you like to find that on somebody? I'm not going to touch you. Don't lay on your stomach. Don't breathe really deep. Yeah, what? Please leave my office now. Where are we now? Somebody said it. A circle of Willis, yeah, and this would be known as a berry aneurysm, okay? And it looks just like a little berry in a stem, doesn't it? Yeah, a little scary there too, huh? Okay, a little scary there too. So arteritis can be from an infection or a toxin. I think that's all pretty, right? Stuff you guys deal with quite a bit. SLE can cause arteries as well. Okay. Thrombophlebitis, okay, venous inflammation that follows thrombosis. This is all bread and butter stuff for you guys are good with this, right? Usually the deep leg veins, right? As opposed to those varicose veins, which are going to affect more of the superficial, right? And we understand the whole premise behind varicose veins, right? The loss of the ability of those valves to keep blood flowing properly. There's a backup into the veins, right? Those superficial veins, and they distend because those walls aren't really thick. So, some of the things to keep in mind for that is obviously, heart failure would be a problem that eventually could cause varicose veins. We're not going to see that as a real byproduct, but damage to the valves over time. Those veins can my uncle had this with no reason. His varicose veins just popped out on one side. Pregnancy, right, is a big one. Abdominal obesity. Because think about it. Where is blood returned? Common iliacs. Where are the common iliacs? Right where, the pregnant belly or the abdominal obesity would be. It pushes on those veins. It doesn't allow blood to flow back in. Okay? All right. So, once again, hemodynamics. A thrombus can form in those because they don't have that normal turbulence, or they have abnormal turbulence, I should say. Okay. Hemorrhoids or varices in anal canals or the rectal veins. Esophageal varices are the veins around the esophagus, okay? Those can distend if we don't have the proper return through that portal circulation into the liver, right? Okay, they can cause distension into those esophageal veins. Okay. Any guesses on this? Anybody ever seen this? No? What artery are we in? Temporal. This is a temporal arteritis. Okay. Some sort of inflammation or infection. So we're on the last slide in an arterial disease has gotten into that temporal artery. Okay. You don't want to press on this, right? Okay. Don't want to press on this because you can damage it. Okay. So temporal arteritis, some sort of infection has happened and gotten into that temporal artery. Okay. Any question? I think it also, giant cell arteritis, I think it's also known as. Okay, but anyway, temporal arteritis is what we'll go
With
with.
something like this, like would they treat that with an antibiotic and that would resolve itself?
Yeah, hopefully. I think that there can be permanent damage with it from what I remember though. Okay. Any questions on arterial stuff before we move on to hot? Be still my heart.
Would that symptoms prior to that, would that be like headaches
Mm-hmm.
and vision problems maybe
Mhm.
from the inflammation?
And obvious differences in pulses, but you don't want to push on it because it can rupture. Any other questions while I'm sort of pulling this up? Here goes our last chapter together. So let's take a look at this really quickly. So our journey will end here, right, at respiratory. So I have gastrointestinal, KUB, and reproductive that I just uploaded as extra. That's, that's not going to be on any tests or quizzes, okay? So, oh, no, that's a quiz. And I won't take it for you. Sorry. Here we go. So I always do that. I don't know why the quizzes catch my eyes. Okay. Okay, I'll play that on break. So heart disease. Are you guys good with the anatomy and physiology of the heart? With the anatomy? More or less? Okay. I find it helpful to make a chart with the four, right atrium, left atrium, right ventricle, left ventricle, what goes in and out. I find that to be helpful, okay? And we kind of understand, oops, there we go. Blood is going to be returned to what side of the heart? The right side of the heart, by the superior and inferior vena cava, right? I'm feeling like I want to review this a little bit. So if you guys know it, that's great. But let's just do a quick little review of the heart. Because a lot of it depends upon that knowledge. And you can kind of sort of figure things out from having that basic anatomical knowledge of the heart. Okay? So, here's our little chart. We've got right atrium, left atrium, right ventricle, left ventricle. Blood comes into what chamber from the body? Right atrium. By what vessels? Superior and inferior vena cava. So superior vena cava is basically going to drain the upper body. Inferior vena cava drains the lower body, okay? And also the liver. The liver will actually send veins into the inferior vena cava. Isn't that smart, right? Because it feeds all that nutrient-rich blood into the inferior vena cava to be sent to the heart, to be sent to the body. Pretty cool, right? So we've got inferior vena cava, and we've got superior vena cava, okay? Now we're going to pump blood out to the body from what chamber? From the heart out to the body, left ventricle, and it will go out by the aorta. Good. Okay, so we have a good feel for that. Right ventricle is going to send blood to the lungs. Oh, good, you guys reviewed. Okay, by the pulmonary trunk. The pulmonary trunk leads to the pulmonary arteries. And then we have that same breakdown. Okay, arteries to arterioles to capillaries, right? Venules, veins. Pulmonary veins send blood back to the heart, to the left atrium. Okay, very good. So pulmonary veins are going to send blood back into the left atrium. Okay, So good. We got the gist of the blood flow. Okay. How about valves? Okay. What valve is going to be here? Tricuspid. Good. What valve is going to be here? Bicuspid. Fantastic. Also known as mitral. Okay. What's here? Very good. Pulmonary semilunar valve. Okay. And what's going to be right here? Aortic semilunar. You guys are good with this. I don't need to review. Okay. Semilunar. Semilar. Okay, semilunar. Okay, good. We're good with that. Any questions? Okay. So it's all a matter of getting it in and then out, right? Okay, because if we're not getting enough in, we can't get enough out, right? If we're not getting enough in, it'll backflow. If it's backflowing out of the right side of the heart, it's going to go to the body. The right side of the heart go to the body, right? If we can't get it out of the right side, right, it'll back up to the body. If we can't get it out of the left side, it'll back up into the lungs, right? Okay. All right. Good. Okay, so basic review. Excellent. So EKG, we're good with this. For the most part, you know, the different leads, the 6 lead, the limb leads, the precordial leads, all that. What is it monitoring though? What's it monitoring? If you're just talking about, the only thing that I could talk to you about is lead 2. That's the only one I understand, okay? Don't ask me about the others. And if you know about the others, come teach me, because I've had a dozen people talk to me and I'm just like, okay. So if anybody has a specialty in EKG, come see me, right? So confusing, okay? So I was hoping for some insight from the book. Okay, so lead 2 is the one I'm going to talk to you about, the typical one that we're all familiar with. But what are we really looking at? What are we looking at? Electrical activity. How do we have electrical activity in the heart? The movement of what?
Electrons.
Movement of ions. So when the heart beats, sodium and potassium are going to move into and out of cells. And that movement of that sodium and potassium is going to create this electrical current. Are you with me? Okay. That electrical current. What contracts first? Atria and then ventricles. Okay, so just laying the groundwork. So atria, then ventricles. Okay, atria contract first together, and then ventricles will contract together second. Okay, good. This will make a normal ECG so much easier. EKG, ECG, you know, interchangeable more or less. I think more people are leaning clinically towards ECG, right? Okay, so normal ECG. Let's take a look at this. Did I write this down in the next? No, okay. So I'm going to zoom my people at home in on the picture. Okay, so normal ECG. Although I always want to say EKG. I'm just going to give you the gist of what each wave means. Okay, and you should probably already know this, but let's go through it. If we're talking about the P wave, okay, this is going to be the beginning of our reading for the EKG, the beginning of the heart, this one particular heartbeat. What does that P wave represent?
Atrial depolarization.
Very good. Atrial depolarization, also known as just plain old contraction. Okay. Now, when the heart muscle contracts, it releases an action potential. Okay. That action potential moves ions. Do you guys remember that? The movement of sodium and potassium and all that, right? Okay. After those ions are released into and out of cells, it has to reset itself. So depolarization is going to simply be the contraction of it. Repolarization is the resetting of that heart muscle. So a P wave is going to be atrial depolarization or contraction. Okay. What's the QRS complex? Ventricular depolarization. Good. And what's the T wave?
Ventricular repolarization.
Ventricular repolarization. Okay, so we're seeing, keep in mind, what it's monitoring is the movement of electrons. That's why they're all in a positive fashion. If any of you are thinking about the action potential, remember there was depolarization, repolarization, hyperpolarization. When we're looking at an EKG, it's the movement of those electrons that are going to cause the spike. And there's a little bit of resetting as well, right? But for the most part, it's going to create that upward movement. Okay? So P wave is going to be atrial depolarization. QRS complex is going to be ventricular depolarization. T wave is ventricular repolarization. I'm sure you know where the atrial repolarization is, right? Sounds like you guys are there. It's hidden where? Yeah. Because that's simply stronger contraction. Good. So you guys are good with this, right? And we're just going over the basics. Basics. Any questions on that? So you guys should be pretty good with the abnormals too, right? Okay. This is on the right side, some variations, okay? We've got a fast heartbeat, which obviously would also be known as what? Tachycardia. Okay, slow heartbeat, which would be bradycardia. We're good with that. Good. But this picture is really good to see that electrical activity going through the heart. You can see it beginning in the SA'd node in that first picture on the left. It sends that electrical signal through both the atria, they contract. Then the AV node will continue that signal down through the ventricles, okay? You could see them contract, and then you could see the ventricles resetting or repolarizing. So I think this is a really good picture to show you that. Any questions on that? Good. So abnormal ECG, this is going to be VFib. What's happening? What's happening with the ventricles during VFib? They quiver. Do you know what the nickname is for it? For that quivering presentation? It looks like a bag of worms. It looks like if you've ever gone fishing and you fill a bag and there's worms squirming around, it's not that atria, then ventricles, then atria, then ventricles. They are very, what's the word I want to look for, what I'm trying to say? I want to say mismatched, uncoordinated. Okay, so VFibs, also known as bag of worms. So if it's uncoordinated, you're not going to have that rhythmic bum, 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 right? You're going to have totally crazy readings on the ECG. Okay. Atrial fibrillation. So what's happening to the waves here? What do we see here? Yeah, no P waves or intermittent P waves that are abnormal, right? Okay, you can have one, then they can go away. Is this as damaging as VFib? No, people can live with AFib, right? Okay, for years until they get that ablation. It's not as damaging. You still have a nice rhythm, right? What's the damage, though, that can happen with AFib with people? Clots. Good. Good. Okay. So ST, depression or elevation, would be seen in what condition? Heart attacks, also known as MI, right? Myocardial infarction will cause this presentation. Okay, good. You guys, I figured you'd be pretty good with that. Any questions? Okay. Preload and afterload. Does that ring a bell? Okay. So preload and afterload, we're going to start talking about that. Preload is going to be exactly that, right? It's loading the heart for contraction. How would you change preload? How would you change preload? So preload is going to be the venous return of blood to the heart, providing the volume that is going to enter the ventricles that will be pumped out. Okay? So how can we affect that preload? How could you affect it? Medications? Absolutely would change it. Exercise could change it, right? If people are hypertensive, aren't they going to have more preload because they're going to have more pressure on the vessels bringing blood back, right? Okay, so anything that would change that supply of blood getting into the heart is going to change preload. Are you with me? Now, what does preload do? How is it going to affect the heart muscle itself? My people at home, cardiac performance, how volumes of blood enter the heart. What's it going to change in the heart muscle itself? I bring people back out for this. This is hard. This is why I'm letting you think about this for a little bit. What does it do to the heart? So suppose I increase preload. I'm going to do what? I'm going to return more blood to the heart, okay? To the right atrium, which will go into the right ventricle, right? Okay. And just more blood in the heart, period, right? What's going to happen to that cardiac muscle? It's going to get stretched. There we go. Okay, it's going to get stretched. Okay. So preload, if you increase preload, you're going to return more blood to the heart. It will stretch the heart. Okay. That can, now we've got it, this gets a little confusing. Okay. We're not talking about somebody who's cardiovascularly fit, who has a heart that has more heart muscle that's pumping more blood per pump. We're talking about people that are hypertensive, that's returning more blood to the heart than should be returned because of the pressure in the vascular system, and it can start to stretch the heart. Now keep in mind, do you guys remember musculoskeletal system from A&P when we talked about muscle fibers? So if I show you a muscle and then we look at the parts of a muscle microscopically, there are little fibers that overlap, right? Actin and myosin, do you remember that? And there's got to be a certain amount of overlap because in order for actin and myosin to shorten the skeletal muscle, guess what it has to do? It has to latch onto it, and then it unlatches. Do you remember that? Yes or no? Okay. It's similar in heart muscle. There's got to be the proper amount of overlap. So if I start to increase preload consistently over and over again, and those muscle fibers get stretched, what's going to happen? I know I keep hearing something buzzing too. They can't do what? They can't contract as efficiently, right? Okay. So preload in that abnormal sense is going to be bad if we stress the heart that way. Okay. Are you with me? Okay. So, also increased by renin-angiotensin. Now, what's ADH? Do you remember ADH? Antidiuretic hormone. Good. So, antidiuretic hormone is released from where? Very good. Posterior pituitary. Just as it says, right? It's going to prevent diuresis. It's going to retain fluid. So, if we retain fluid, we're going to do what to blood pressure? Increase blood pressure will increase preload as well. Okay? Are you with me? Good. So preload. So we talked about preload, but in addition to that, on the other end of the heart, if we don't have vascular compliance, if we have hardening of blood vessels, is it going to be easier for the heart to push blood out of it, or it's going to be harder for the heart to push blood out? It's going to be harder. That's afterload. Okay, when you get that vascular resistance either from idiopathic hypertension or essential hypertension, or if you have hardening of the vessels, you can't push, I keep moving out of the screen, you can't push blood out of the heart as efficiently, okay? So you can start to see how these disease processes will affect the heart as well as systemic circulation, okay? So preload, pressure on the end of the heart. The other thing to think about preload, and this gets so crazy to think about, preload will be end diastolic volume. Okay? When does the heart fill with blood? During diastole. Okay, remember diastole is when the heart muscle is relaxing. Blood can enter the heart, then fill the ventricles, goes through the atria, through the ventricles, and then systole is when the heart contracts. So preload is going to contribute to that end diastolic volume. The end of relaxation, the higher the preload, the more blood you will have in the heart to pump out. Okay, so those are kind of interrelated. Okay, so Starling's law of the heart. Did you ever go over this? Yes? No? Sort of? Okay, heart adapts to different preloads by pumping the volumes of blood delivered to it. Okay, So if we're returning more blood to the heart, you're going to have more preload, you're going to have more stress on the heart to pump that out. Kind of makes sense, right? Okay, kind of makes sense. Any questions on that? It's kind of heady stuff. We good? Go with it. It's amazing when you really think about it, how healthy our hearts are with all the stressors that they're put under. How are we with cardiac vessels? Pretty good? Okay. So coronary arteries. What are the two main coronary arteries and where do they come from? Is this where we are? Yeah. Or do we need a little review? Yes, no? Guys are starting, you're like, I just want to be done with this class. Okay. If we, oh, I have a picture. Picture's worth 1,000 words. I was going to try to draw it and I was starting to panic because you know I can't draw. Okay, so here's the coronary arteries of the heart. Let's talk about these. People at home, I'm going to zoom you in so you can see it. Okay, so where do the coronary arteries come from? Yeah, they come right off the aorta. So where the aorta comes from the left ventricle, as it leaves the left ventricle, as part of it is like intimal into the wall of the left ventricle, as it comes out, you've got the right and the left coronary artery. Okay, really brilliant design, isn't it? Okay, so the right coronary artery, if we can just sort of look at the picture really quick, the right coronary artery is going to supply the right side of the heart. Okay, and it's going to wrap around to form that posterior descending that actually will go to the back part of the left and right ventricles. Okay. Left coronary is going to form the circumflex, which is going to wrap around, but also the left anterior descending, which quite often gets blocked, right, and causes MIs. It's a big problem that they find because who's going to be the major pumper for the heart? The left ventricle. You block that anterior descending, you're not going to have the proper blood supply to that left ventricle. It can't pump blood out to the body. Okay, it's a big one. Okay, so left anterior descending. For the most part, just really quickly, going off book a little bit, okay, that posterior descending, guys, comes from the right coronary artery. In some people, it comes from the left. Now, that's bad because now we have all the major blood supply coming from the left coronary artery. If they throw a clot in their left coronary artery, that's what they call a widow's maker. Have you heard of that reference? Okay, so that's where that change comes from. This right coronary artery usually serves or leads to that posterior descending. For people that have a widow's maker, the left coronary will supply that posterior and anterior descending, which sends the blood supply to that left ventricle. Okay, that's what causes that widow's maker. Blood supply gets cut off to that, boom, your left ventricle is done. Okay. Okay. Any questions on that? So there's more than that, but as long as you know left and right coronary artery, anterior and posterior descending, I think those are sufficient. Okay. Control of cardiac perfusion. So there's so much with this. Give me just a second to read ahead a little bit. Okay. So the heart needs constant perfusion of blood supply to the heart muscle itself. Keep in mind, guys, that you're not going to absorb any nutrients or any oxygen from the blood inside the heart for the cardiac muscle. It all comes from those coronary arteries. So they've got to be very strongly regulated. Okay. Nitric oxide is going to be the main vasodilator. Okay. So if the heart muscle starts to sense that it's not getting enough blood supply, it'll release nitric oxide right from the endothelium. It'll vasodilate or relax that blood vessel. Okay. On the opposite side, we have endothelin 1. That's going to be a constrictor. So if the heart muscle senses that it's getting too much, because those vessels are pretty small too, you don't want to blow them out. So that's why we're going to cause vasoconstriction in areas. We don't want to cause too much pressure and damage the blood vessel itself. So if there's too high of a pressure, you release endothelium, it'll cause it'll cause that vasoconstriction. So these two biochemicals will regulate vasodilation and constriction right in the heart blood vessels, or the coronary arteries, I should say, themselves. Okay. When blood vessels are damaged, though, they won't release nitric oxide when they need to relax and endothelium when they need to contract. So not only do you have plaquing and damage, you'll also have an abnormality of a release of those biochemicals. Okay, so kind of, we talked about that when we were talking last chapter. Okay, so heart disease. You can sort of limp along with atrial problems. You really can't with ventricular problems, right? It's going to cause a lot of dysfunction either into the lungs or into the body. Okay, so ventricles are going to be a biggie with this. We're good with this anatomy. We just went through it. Okay, here's an actual picture of it. I like to write it as a chart. It helps me to sort of keep it organized a little bit better, but here's a picture of it. I like this picture. Kind of brings everything all together. Okay. Good. I was looking for the, anyway. So, okay, so heart failure should be pretty good with this, right? There can be acute, there can be, long-term progression of chronic. So left-sided versus right-sided. So why is the left ventricle the most common to fail? Does anybody know? I sort of skipped that top paragraph, because I figured you could read through. It's all the causes of heart failure, okay? But why is the left ventricle the most common to fail?
Because it has to pump so hard to the body.
That's a great guess. And kind of spinning off of that, how thick are the ventricles compared to the atria? Very thick. The atria looks like a thin wall. Okay. How big is the left ventricle compared to the right ventricle? Pretty big. Okay. So it's definitely working much harder. When it works harder, what can it compress in it? I was totally thinking about this today as I was walking up the hill with my father-in-law. His heart problems. And I know his heart was working harder because he was pushing my boys in a stroller and it was, 8,000 degrees. So as that left ventricle is pumping, think about the blood supply to it. Mm-hmm. When it's contracting, what's going to happen to the blood supply to the left ventricle?
Not as much pressure going into
It stops, right? It gets all of the myocardium or the heart muscle itself in the left ventricle gets all of its blood supply during diastole. When it's contracting, it contracts so hard, it's going to close off those blood vessels. So it's not going to have a consistent blood supply. So it's going to be more stressed. Okay? It also has to pump out through the aorta to the whole body. Okay, so it's going to work harder. Okay. Good. What happens when the left ventricle stops pumping? Go through the steps. What's it going to stop doing? Supplying blood. I know the first guy who's going to start to be damaged is going to be the brain, right? Because you need a consistent supply of oxygen. So why does blood pressure rise with left-sided heart failure? Why does blood pressure rise with left-sided heart failure? And we've actually talked about it already. I'm going to sit down. I'm going to let you guys do this work. Think about the mechanisms. What was that noise? So don't think of like an acute, quick, like left-sided heart failure. Think of more of a slow, progressive left-sided heart failure. Why would blood pressure start to rise? Who's going to start lacking blood supply? The heart. Think about one of the systems, another organ system that we talked about before, who doesn't like low blood pressure. Kidneys, right? The kidneys will sense that decreasing blood pressure and kick in the renin-angiotensin system, okay, and start to raise blood pressure, okay? So what happens when the right ventricle stops pumping blood? What's going to happen? Absolutely. Decreased amount of, oh my God, there's a dog running around out there. Oh, let's take a break. I gotta go save a dog. Does it have a little master with it? Does it? Okay, good. I'm like the dog whisperer. Like all stray dogs come to me. Just a quick story, and then I'll give you a quick break. My dog never ever barks, and she was barking at our back door, so I thought somebody was there, and I walked out, and there was a 120-pound dog standing there. I was like, oh, okay. Oh, actually, let's finish these last couple questions. Sorry, people at home, there was a dog running around outside. I thought it was without a home. Okay, so what happens when the right ventricle stops pumping blood? She was like, darn, I thought I almost got out. So yeah, absolutely. So obviously the left ventricle will stop pumping so much blood, okay? Decreased oxygenation to the tissues, cyanosis, and also what? So think backwards now. What's going to happen with the blood? It's going to back up into the... It's so confusing. Right ventricle stops pumping it to the lungs. It's going to back up into the right atrium, out to the body, into the body, and cause edema. So there'll be a lack of oxygenated blood going out. There could also be systemic edema, right? What'll happen if we have left-sided heart failure, edema-wise? Let's talk about, you would get what type of edema with left-sided heart failure? Pulmonary, right? So think about where it's backing up to. That's why the heart is so hard. The heart is hard because, first of all, there's 4 chambers. They actually start as 2, then they divide into 4, then they twist. That's why the heart anatomically is so difficult to study, but it's also difficult because you've got to think about where it's going and where it's been, right? Where blood is going and where it's been. So it gets a little confusing, okay? Why would, now here's another step further. What's hepatomegaly? We're good with that, right? Hepatomegaly is going to be increased size of the liver. What's splenomegaly? The spleen, very good. So why do we get hepatomegaly and eventually splenomegaly if we have right-sided heart failure? I don't really any heart failure, but right side has got to be implicated. That's a hard one. Think of your anatomy. I just mentioned that the liver drains into the aorta. There's a whole bunch. The liver looks almost a little porous, okay, at this area where it joins up with the inferior vena cava. I'm sorry, did I say aorta? Inferior vena cava. Okay, and it wraps right around the inferior vena cava. Okay, well, sort of, around the backside. There are veins that put processed blood. So we gather up all the nutrients from our GI tract, we put into the liver processes it in many different ways, and it sends blood into the inferior vena cava. Inferior vena cava to the right atrium, yes? Okay, so if blood backs up from the right side of the heart into the inferior vena cava, well, it doesn't make sense. It's going to back up into the liver. Now, the other thing is that when we break down red blood cells, we break them down in the spleen, we send all those byproducts to the liver. There's a vein that goes right across from spleen to liver, okay? And then the liver processes it, you know, either excretes it in bile or whatever it may be doing, or it sends it to the heart. So if you think about it, now, right side of the heart is going to go back to the liver through the inferior vena cava, then back to the spleen, and you could get enlargement of those organs, okay? And obviously these patients are going to be cold with blue extremities because they're not getting oxygenated and warm blood. Okay, good. Let's take a quick little 5-minute break, and I will see you back here. We almost, wow, this is a lot of material. I'm gonna have to speed it up because I do want to finish it in the next hour. All right, I will check the emails if anybody has any questions. Do you guys have any questions? No? Good.